Okay, so let's start today. So everybody knows me. I'm Raj Singh. I'm one of the dermatopathologists working at Mount Sinai. So what I'm going to present today is because the board exams were very close, so we prepared this lecture. 15 diagnoses in inflammatory dermatopathology every path resident should know. So we'll have like 15 slides that you can first look at, and then we'll go over the features that you need to look for to make the diagnosis. So case 1. So here is a slide here for case 1. So what do you see in slide 1 actually? So like I always tell the residents, start from either the top or the bottom actually. So if you start from the top, what do you see on the top actually? Parakeratosis in the epidermis. You can see all these keratinocytes. There's spaces in between the keratinocytes, so there is fluid in between them. So there's some mild spongiosis, and in the dermis, we see a mild perivascular inflammation. So it's some sort of a spongiotic process going on. But what are so when you look at the dermal inflammation, which are the cells that you see in the dermis? What are these cells here?
Lymphocytes.
Yes.
These are the round ones are lymphocytes, where the multilobulated ones. Pardon? Neutrophils. So whenever you see neutrophils, the first thing that should come to your mind is, like I should always look for psoriasis is one, but also any fungal infection actually. So you always think of fungal infection. So when you think of fungal infection, the next thing you want to do is a PAS stain actually. So here's another slide with the PAS stain. And you can see all the hyphae within the stratum corneum. So whenever you see neutrophils within the stratum corneum and within the epidermis, always think of a fungal infection. And a very common thing which can be treated very easily. The patient doesn't have to be put on steroids or anything, just antifungal cream would help the patient out actually. So always very important to think of fungal infection whenever you see neutrophils either in the epidermis, dermis or in the stratum corneum. So the diagnosis would be dermatophytosis. Like I said, what are the clues to making the diagnosis? One is the sandwich sign, which is presence of neutrophils in the stratum corneum. Like I said, presence of neutrophils should always make you think of a fungal infection, and I keep stressing what the mind doesn't know, the eyes will not see actually. So you have to first think of it, and once you think about it, then you're going to do the fungal stain, and once you do the fungal stain, you're going to find the fungus within the stratum corneum. So when you go back to the slide, in Path Presenter, what you can do is you can annotate the slide. So you can there you can see the annotation. So the neutrophils and so this is the sandwich sign. When you see the neutrophils between parakeratosis, so this is parakeratosis, hyperkeratosis, and the neutrophils within the stratum corneum, that is the sandwich sign. It's like a sandwich of neutrophils between two parakeratoses actually. So what is the main differential diagnosis for a fungal infection is erythema. So what is erythema? Erythema is a cornebacterial infection that occurs in the axilla or in any intertriginous areas. Again, very subtle. All you're going to see is presence of these bacteria, bacilli within the stratum corneum. Again, like if you don't think about it, you're going to miss the diagnosis, because if you look at low power, it looks like very normal skin actually. There's nothing much to say that there's anything wrong in this biopsy except for this mild lymphocytic infiltrate. But when you start going high power and start looking at the stratum corneum, you're going to see this cornebacterial bacilli, which are very nicely visible if you do a gram stain actually. So that is case 1. Let's move on to case 2. So what do we see here now? Again, start from the top. So what do you see on the top? Not much. This is just basket weave hyperkeratosis. There's some focal parakeratosis which you can see here. Some focal parakeratosis. What do you see in the epidermis? Spongiosis actually. So again, mild parakeratosis, spongiosis, and then in the dermis we see a superficial perivascular lymphocytic infiltrate. So what is your diagnosis then? What is the main thing to think of? A very common thing that you're going to see, the patient comes to the dermatologist with pruritus, eczema actually. It's a very common thing to think of. So what is your diagnosis here? Allergic contact dermatitis. And what are the features that you want to see for? The main action is in the epidermis and the superficial dermis. So spongiotic changes that you see in the epidermis, and you might see some eosinophils, but presence, you don't need to have eosinophils to make a diagnosis of a spongiotic process. If you see the eosinophils, it is just telling you that this could be an allergic process, but you don't have to have the eosinophils to make the diagnosis. What is the main differential diagnosis that you need to always think of is PR actually. Another very common skin rash that you're going to see even if you're not practicing dermatopathology. So what are the features that you want to see in the biopsy to make the diagnosis of pityriasis rosea? So what are the main features that you are going to see in PR? Again, it is the differential diagnosis of an eczematous process. So the same thing, parakeratosis, spongiotic changes in the epidermis, and then perivascular lymphocytic infiltrate. But what should make you think that this could be PR is when the parakeratosis is present in mounds actually. So this is known as a mound of parakeratosis. So if you see parakeratosis that is present in mounds, spongiotic changes in the epidermis, perivascular lymphocytic infiltrate, and then the other characteristic feature most of the times you're going to see is the red cell extravasation. So very characteristically seen this red cell extravasation that you see in the dermis. So mounds of parakeratosis on the top, spongiotic changes in the epidermis, superficial perivascular lymphocytic infiltrate with red cell extravasation should make you think of this could be PR actually. So pityriasis rosea. Case 3. So what do we see here again, starting from the top? Hyperkeratosis, and then within the hyperkeratosis you see a lot of parakeratosis. So you see almost like a confluent parakeratosis. Anything else that you see in the stratum corneum? Neutrophils. So whenever you see neutrophils in the stratum corneum, first thing to think of is fungus. But what is the other most common thing or common rash that is going to show you neutrophils in the stratum corneum? Psoriasis actually. So you always need neutrophils in the stratum corneum to make the diagnosis of psoriasis actually. So what are the other? So once you start thinking of psoriasis, what are the other features? So confluent parakeratosis, presence of neutrophils, neutrophilic abscesses in the stratum corneum. When you look at the epidermis, you see this thickened bulbous rete and that is known as psoriasiform hyperplasia. So psoriasiform hyperplasia is this bulbous rete or thickened rete. You go high power, the other characteristic feature that you're going to see is the loss of, so this is the granular layer that you see here. So what do you mean by granules? So in the granular layer you see this granules. So this is the stratum corneum and this is the granular layer. Normally the granular layer is throughout the epidermis, throughout the upper layer of the epidermis. But in psoriasis, in many places you're going to see the loss of the granular layer. So the granular layer is completely gone. So confluent parakeratosis, neutrophilic abscesses, loss of granular layer, psoriasiform hyperplasia. The other characteristic feature is when you read the books, they are going to talk about thinning of suprapapillary plates. So so what is papillae? It is the dermal papillae. So this is known as the dermal papillae, the part of the dermis that is projecting between the rete. And the part of the epidermis above the papillae is the suprapapillary. So thinning of the suprapapillary plate. So this is normal this part is normal here. So this from here to here, this is the normal suprapapillary plate, but in quite a few areas you're going to see this plate is becoming thinned actually. So the portion of epidermis thins out actually. So this is thinning of the suprapapillary plate. And then within the dermal papillae you're going to see a large number of increased capillaries. And then the other feature is superficial perivascular lymphocytic infiltrate. So let's go over all the features of psoriasis again. Confluent parakeratosis, presence of neutrophils in the stratum corneum, psoriasiform hyperplasia, loss of the granular layer of the epidermis, thinning of the suprapapillary plate, increased capillaries in the dermal papillae, and then superficial perivascular lymphocytic infiltrate. So these are all the features that you want to look for when you want to make a diagnosis of psoriasis. What are the differential diagnoses? So like I said, neutrophilic microabscesses is the main clue that should make you think of psoriasis as the main differential diagnosis. So subacute chronic eczematous dermatitis can also present with a psoriasiform hyperplasia, but you are never going to see the neutrophils in the stratum corneum. Lichen simplex chronicus can also present as a psoriasiform hyperplasia, but again the neutrophils are not going to be present in the stratum corneum. So the presence of neutrophils is very critical to help you make the diagnosis of psoriasis. So here is an example of lichen simplex chronicus. So again you see the psoriasiform hyperplasia, but then when you go high power, yes, there is parakeratosis on the top, but if you go throughout the parakeratosis, you are not going to see any neutrophilic microabscesses. And what is lichen simplex chronicus? The patient, when he scratches, it causes the skin to react, and that is lichen simplex chronicus. So this is all reaction of the skin to repeated trauma or repeated scratching. So how is the skin going to react? Hyperkeratosis, parakeratosis, the epidermis is going to become acanthotic, which means thickened, and in the dermis you're going to see some fibrosis. Characteristically, many books describe is the collagen bundles and the blood vessels running perpendicular to the epidermis. So you're going to see all these collagen bundles and blood vessels running almost perpendicular to the epidermis. But what is missing is the presence of the neutrophils that help you that this is not psoriasis. Case 4. So again, starting from the top, what do we see on the top? Hyperkeratosis, but no parakeratosis. You don't see any nuclei within the stratum corneum. All you are seeing is a thickened stratum corneum, which is hyperkeratosis. Then in the epidermis, what do we see? You saw the granular layer in the last one basically. In this one, the granular layer, is it normal or is it more than what you saw in the last one? So this is actually more than what you saw in the last one. So you have this wedge-shaped hypergranulosis. It's almost like a wedge shape. So you have hyperkeratosis on the top, wedge-shaped hypergranulosis, and very characteristically, what do you see in the dermis? Lichenoid infiltrate actually. So you see a dense lymphocytic infiltrate which is hugging the dermal epidermal junction. So lichenoid infiltrate is different from a perivascular infiltrate in the dermis. If the infiltrate is around the blood vessels, it is a perivascular infiltrate. If the infiltrate is hugging the dermal epidermal junction. So what do I mean by hugging? So you look at this, it is almost obscuring the dermal epidermal junction. That is a lichenoid infiltrate. So you see this dense lichenoid infiltrate at the dermal epidermal junction, and because the lymphocytes are attacking the dermal epidermal junction, some of the keratinocytes, they go into apoptosis, and you see this apoptotic keratinocytes, which in different books are described as Civate bodies, colloid bodies. They all have different names, but they all are apoptotic keratinocytes. So hyperkeratosis, wedge-shaped hypergranulosis, dense lichenoid infiltrate at the dermal epidermal junction with associated dyskeratotic cells or colloid bodies. What is your diagnosis? What is the reaction pattern here? It is a lichenoid dermatitis. So what is the prototypical lesion that you should know? Lichen simplex chronicus, we just saw that doesn't have that actual lichenoid infiltrate actually. So this is lichen planus actually. So this is another common skin rash that you're going to see even if you're not practicing pure dermatopathology. So even you're just practicing pathology, you are going to see biopsies of lichen planus. So it is important to learn to recognize lichen planus. So hyperkeratosis, no parakeratosis, wedge-shaped hypergranulosis, dense lichenoid infiltrate at the dermal epidermal junction, and scattered dyskeratotic cells. Diagnosis is lichen planus. So what were the clues? The lack of parakeratosis, and usually you don't see any eosinophils in the lichenoid infiltrate. So if I see parakeratosis or eosinophils, my differential diagnosis is either it's a lichen planus like keratosis or a lichenoid drug eruption. Now one thing to remember is lichen planus like keratosis can 100% look very similar to lichen planus. You don't always have the parakeratosis. It is the clinical picture that helps you differentiate between lichen planus and lichen planus like keratosis. So if the requisition form is saying rule out BCC, rule out actinic keratosis, that tells you that the patient has a single lesion. So if it is a single lesion and it looks like the biopsy that we saw, then your diagnosis is going to be lichen planus like keratosis. If it comes in as rule out a rash, then your diagnosis is going to be lichen planus. Histologically, both of them are going to look exactly the same. You don't always have to have the parakeratosis to call it lichen planus like keratosis. It is the clinical history that is very, very important to differentiate between lichen planus like keratosis and lichenoid and lichen planus. So if you don't have a history, you have to pick up the phone and talk to your clinician, like what is it, a single lesion or is it a rash? And if there is no way that you can get a history, then all you say is lichenoid dermatitis, see comment, and in the comment differential diagnosis includes lichen planus and lichen planus like keratosis. Clinico-pathological correlation is recommended. And for lichenoid drug eruption always, what do you want to see in drug eruption? Eosinophils actually. So when you have so this is an example of a lichen planus like keratosis. I won't go into too much detail, exactly the same features. So hyperkeratosis, wedge-shaped hypergranulosis, lichenoid infiltrate and dyskeratotic keratinocytes. But the history is going to tell you if this is LP, LK or is it lichen planus. And when you come to a lichenoid drug eruption, what you want to see is the presence of eosinophils. So what you need to do is go high power and then scan the dermal epidermal junction very carefully to look for this eosinophils. If you see the eosinophils, then it is most likely not lichen planus, it is lichenoid drug eruption actually. So you just go high power and then just look for eosinophils actually. Otherwise, low power, it looks exactly the same as lichen planus actually. So you have the wedge-shaped hypergranulosis, lichenoid infiltrate, everything looks the same, but when you go zoom in and you look for eosinophils, you are going to find the eosinophils there actually. Case 5. So again, starting from the top, what do we see on the top? Just basket weave, normal hyperkeratosis. So this is known as basket weave because it has the features of a net like, and that is normal pattern of hyperkeratosis. In the epidermis, what do we see? What are these cells here? You see a lot of those pink keratinocytes. So when you see this pink keratinocytes, these are apoptotic keratinocytes, and these are known as dyskeratotic cells actually. So you see a lot of dyskeratotic keratinocytes throughout the epidermis. So look at these dyskeratotic keratinocytes throughout the epidermis. An important diagnosis to know because this can come as a frozen also. So basket weave hyperkeratosis, dyskeratotic keratinocytes in the epidermis, and what do we see at the dermal epidermal junction? All these vacuoles that you see at the dermal epidermal junction. So this vacuoles, what are they telling you? That this is a vacuolar reaction pattern. So all these vacuoles that you see here is a pattern of interface dermatitis. Interface means interface of the dermis and the epidermis. So that is known as interface dermatitis, and interface dermatitis can be two types. Either it could be the lichenoid reaction pattern that you saw in the previous one, or it could be all these vacuoles at the dermal epidermal junction with few lymphocytes actually. So with few lymphocytes, vacuolar interface changes. So, and then in the dermis, we see a mild superficial perivascular lymphocytic infiltrate. Maybe some eosinophils, but mostly lymphocytes in the dermis. So what is your diagnosis? Erythema multiforme. Very good, because that is an important diagnosis that you need to know, because this can come as a frozen section also. So what are the features of erythema multiforme? Basket weave hyperkeratosis. And what is the basket weave hyperkeratosis telling you is that this is a very acute process. The skin doesn't have time to react and develop parakeratosis. Something has happened very acutely actually. And the epidermis is going to show you a lot of dyskeratotic keratinocytes. There is vacuolar interface changes at the dermal epidermal junction, and then a superficial perivascular lymphocytic infiltrate plus or minus eosinophils, and your diagnosis is going to be erythema multiforme. What is the main differential? Let's first, so what were the clues? The vacuolar interface changes with dyskeratotic cells in the epidermis and acute stratum corneum, that is the basket weave pattern of hyperkeratosis. What are the two main differential diagnoses that you need to know? Is acute graft versus host disease and fixed drug eruption. Now toxic epidermal necrolysis is something very important, because this is another frozen that you can get actually. And what is toxic epidermal? It is just a more acute variant of erythema multiforme. So instead of the dyskeratotic keratinocytes, let's go to so again you are going to see the basket weave pattern on the top and a lot of dyskeratotic keratinocytes, but when the process becomes so extensive that there is almost like full thickness necrosis of the epidermis, then it is called toxic epidermal necrolysis actually. So again you see the dyskeratotic cells, but the process has become so extensive that it is almost like a full thickness necrosis of the epidermis, which is now causing it to split away from, because it is necrotic, it is causing it to split away. So you see almost like a bulla forming and where does the bulla form? It forms at the interface of the epidermis and the dermis. So in toxic epidermal necrolysis, the bulla, the level of the bulla is subepidermal, because the epidermis is necrotic and completely sloughed off from the dermis. And that is the important thing to see in a frozen, is where is the bulla and what is the status of the epidermis. So if you see the bulla is subepidermal and there is complete necrosis of the epidermis, lot of dyskeratotic cells, then you are going to call it toxic epidermal necrolysis. And in the frozen, what is your main differential diagnosis that the clinician wants you to differentiate it from actually? They want you to tell them, is it toxic epidermal necrolysis or Steven-Johnson is another way, it's just like a same thing as toxic epidermal necrolysis, but staphylococcal scalded skin syndrome, because the management is going to completely differ actually. So they want you to tell, like whenever you get a frozen at 2 o'clock in the night, it's going to be tell me whether it is staphylococcal scalded skin syndrome or is it toxic epidermal necrolysis actually. So in toxic epidermal, we have a slide that is coming up for SSSS, so we'll look at that. But remember, the split in toxic epidermal necrolysis is subepidermal with complete necrosis of the epidermis. And this is an example of a graft versus host disease. So it is in the differential diagnosis of erythema multiforme. So again you are going to see the same features, that you see a lot of, what are these cells here? Dyskeratotic keratinocytes again. So you are going to see them a lot basically, but here you don't see the basket weave pattern on the top, and many times it involves the hair follicle actually. So in acute graft versus host disease, the degree of dyskeratosis is not as that you see in erythema multiforme. There is no basket weave hyperkeratosis on the top, and usually it involves a hair follicle. Again, the clinical history is going to be very important. Does the patient have a history of some transplant that has happened in the recent past actually? And if you have that history, you see this feature, then you're going to call this acute graft versus host disease actually. This was the toxic epidermal necrolysis. So let's move on to case 6. So now what do we have here? So what do we have here? So this is a bulla actually. So you have a bulla actually. So you have a, and when you see a bulla, the first thing to ask yourself is, where is the bulla actually? So this is subepidermal. So you have a subepidermal bulla. So when you have a subepidermal bulla, you need to go down into the epidermis and look for eosinophils. So you see all this eosinophils here. So that is the subepidermal split, and there is the eosinophil. You can see the eosinophils there actually. So if you see eosinophils, what is your subepidermal split with eosinophils? What is your diagnosis? So your diagnosis is going to be bullous pemphigoid actually. Now what is the main differential diagnosis for bullous pemphigoid? Sorry, when you, this is not, I just put this because these are important to know for the boards, but when you see a subepidermal split with eosinophils, you are going to think of bullous arthropod bite and a bullous drug eruption. The other important diagnosis that you need to know for your board exam or as a pathologist is, one is linear IgA vesicular bullous disorder and the other is DH. So what do you see in linear IgA? Again the split is where is the split here again? Subepidermal. But now what are the main cell type that you see here? Neutrophils actually. So if you see a subepidermal split with neutrophils lining the dermal epidermal, so these are almost like lining the dermal epidermal junction, then you're going to think of linear IgA vesicular bullous disorder, and you can recommend that please do an immunofluorescence, and in the immunofluorescence you're going to see a linear IgA at the dermal epidermal junction actually. And for DH, what is the main feature that you see in DH? What are these? Neutrophilic abscesses in the dermal papillae. So when you see neutrophilic abscesses in the dermal papillae, you're going to think of dermatitis herpetiformis. These are slides that you're going to get on the board exam definitely, because these are diagnoses that you can make without any history actually. So you might get these cases on the board exam to make the diagnosis. So I put them here so that you know that what are the features that you need to see to make a diagnosis of dermatitis herpetiformis. So neutrophilic abscesses in the dermal papillae. Case 7. So what do we see here now? What has happened to the epidermis here? It's eroded actually, so it's sloughed off. So where is the split now? In the epidermis. So now when you look at the, what do you see here? So here is the epidermis and this part of it is sloughed off, but what is still pending here? Basal cell layer actually. So the basal cell layer is still preserved. So the level of the split is intraepidermal but suprabasal. So when you see an intraepidermal split with suprabasal, what is your main thing to think of? Pemphigus vulgaris actually. So what do we see here? Here is the suprabasal split, and very characteristically they describe the row of tombstones. So what do you mean by row of tombstones? Is the preserved basal layer that is still hugging the dermis actually. So these are like tombstones that you see here. So row of tombstones is very, very characteristic for Pemphigus vulgaris actually. And you'll read about, whenever you read about Pemphigus vulgaris, they will talk about a row of tombstones, and this is the preserved basal layer that is still present hugging the dermis actually. And very characteristically, Pemphigus vulgaris always involves the hair follicle actually. So you see this hair follicle, and if you see a hair follicle, it is always involving the hair follicle, and that is very characteristic of Pemphigus vulgaris. The main differential diagnosis is Haley, which will not involve the hair follicle. So if you see something that looks very similar but is not involving the hair follicle, you have to think, could this be Haley? The only way to differentiate would be to do a immunofluorescence. So in immunofluorescence, you are going to see the chicken wire or the network pattern of IgG and C3 in the epidermis if it is Pemphigus vulgaris, and that is another image that you can get on the board exam. So on the board exam, you can get a immunofluorescence that shows you a chicken wire pattern within the epidermis. So it is just like, what do I mean by chicken wire pattern? So let's go to the, so here within the epidermis, the keratinocytic lining, all the keratinocytes, you will see the, so immunofluorescence is going to go around this keratinocytes actually, because, and that is known as a chicken wire pattern actually, because in the epidermis the keratinocyte all the IgG is seen deposition around the keratinocytes actually. So pemphigus vulgaris. So very important, what is the most important clue is the suprabasal split with tombstone pattern actually. So main differential diagnosis, Haley disease, and like I said, you need to know how to differentiate, how to make the diagnosis of staphylococcal scalded skin syndrome. So in Haley, so this is for staphylococcal scalded skin syndrome. So what do we see here now? So again there is a split. So there is a bulla formation, but where is this bulla forming now? In the toxic epidermal necrolysis, the bulla was subepidermal, but here it is within the epidermis, just below the stratum corneum actually. So it's a subcorneal split. So this is important to differentiate. This will help you differentiate between toxic epidermal necrolysis and the SSA. In the staphylococcal scalded skin syndrome, what you are going to see is the split, subcorneal split. So this is the stratum corneum and the subcorneal split with some few acantholytic cells. So what do I mean by acantholytic cells? Are these keratinocytes that are seen floating within the bulla actually, and usually you don't see any inflammation. So you just see subcorneal split with scattered acantholytic cells and usually no inflammation. Important to know because this can come as a frozen fire when you are in practice actually. And in Haley there you can again see the split within the epidermis, and this has been described as a dilapidated brick wall actually. So you have this layer here and then upper layer here and a lot of acantholytic cells, and if there is a hair follicle, it's not going to be involved in Haley. But the only way to 100% make the diagnosis is do an immunofluorescence. If the IgG and C3, the network, like the chicken wire or the network pattern is seen in pemphigus vulgaris, in Haley there is no immunofluorescence, it is negative actually. Case 8. So what do we see? Again you start from the top. Not much actually in the, so stratum corneum looks normal. The epidermis also looks okay, basically doesn't look atypical. Then you look at the dermal epidermal junction. What do we see at the dermal epidermal junction? You again see the holes at the dermal. So when you see the holes, what is the pattern? Vacuolar interface dermatitis. So you see vacuolar interface dermatitis, but what is the other characteristic feature that you are now seeing when you look at it at low power? See a lot of inflammation in the dermis. And where is the inflammation? It is perifollicular and vascular. So you see a perivascular and a perifollicular inflammation in the dermis. It's mostly composed of lymphocytes. So it's a predominantly lymphocytic infiltrate that is perivascular and perifollicular with a vacuolar interface dermatitis at the dermal epidermal junction. So what is your main diagnosis? Lupus actually. Good, very good actually. So you're going to think of connective tissue disease. So when you think of connective tissue disease, you do a PAS stain and you do the mucin stain. With the PAS stain, many times you're going to see increased or thickened basement membrane at the dermal epidermal junction, which is not always present, but definitely you're going to see increased mucin with the colloidal ion. So you can do an Alcian blue stain or you can do a colloidal ion stain, and you're going to see increased mucin in the dermis. So vacuolar interface changes at the dermal epidermal junction, perivascular and periadnexal lymphocytic infiltrate in the dermis, and then increase mucin. And then you ask the clinician that they can do the serology, so they can do the ANA, the double stranded DNA, to confirm the diagnosis that this is truly connective tissue disease. So whenever you lupus erythematosus, so what are the clues? Again, the vascular interface changes with perivascular and periadnexal inflammation. If you see this, you're going to think of connective tissue disease. Main differential diagnosis is drug eruption and pleva actually. So for drug eruption, again, what do you want to see in the dermis? You want to see a lot of eosinophils actually. So you go into the infiltrate, you look carefully. If you see eosinophils, then you're going to think of drug eruption. Pleva is another diagnosis that is not important for the board exam, but important to recognize because it's a common diagnosis that you're going to see actually. So what do we see in pleva actually? So pleva is pityriasis, lichenitis et variola. So don't go into the big names, just remember pleva actually. Because if you many times people get what do you call it, like when you see too many big names, then you feel like, oh, this is too much of a daunting task to remember actually. But there are don't go into the big names in dermatopathology. They try to give a lot of different names to very common rashes actually. So pleva is easy to remember. So in pleva, what you want to see is hyperkeratosis and parakeratosis on the top. Again, a lot of dyskeratotic cells in the epidermis, a lot of lymphocytes going into the epidermis, and then very characteristically, almost like a wedge-shaped infiltrate in the dermis actually. So wedge-shaped infiltrate in the dermis, you'll see dyskeratotic cells, and then you're going to see this wedge-shaped infiltrate. So if you see that, and most of the times the clinician is going to tell you rule out pleva actually, because the clinical presentation is very, very classic. It is usually a young patient with multiple lesions that look like pustules all over the body actually, and it's usually a young kid, so most of the time they know this is pleva actually, so it will come in as rule out pleva, and then you only have to like say the histological features are compatible with the clinical impression of pleva actually, but important to know as a pathologist. Case 9. So where is the main action here? The dermis, there's some parakeratosis, but the epidermis looks pretty normal, but the main action is in the, what do we see in the dermis? Inflammation that is superficial and mid-dermal actually. So you see inflammation that is superficial and mid-dermal. And what is the cell type, predominant cell type? A lot of lymphocytes, but there are also a lot of, what are these? Eosinophils. So perivascular. So what do you see here is all this eosinophils. So all these eosinophils with perivascular inflammation. So there's perivascular inflammation with eosinophils. So what is your diagnosis? Most common thing to think of with eosinophils is drug eruption. So your diagnosis is going to be drug eruption. And what is your, so common things for, so perivascular inflammation with eosinophils should make you think of a drug eruption. Main differential diagnosis, arthropod bite, and one thing to remember is always some prodromal or urticarial phase of a vesicular bullous disorder like bullous pemphigoid. So in arthropod bite, again you are going to see superficial and deep perivascular inflammation with a ton of eosinophils. Look at all these eosinophils actually. And most of the times what I have seen in arthropod bite is the eosinophils tend to go almost into the subcutis actually. So if you see superficial and deep perivascular inflammation with a lot of eosinophils which you see here, it's going to be arthropod bite. But again, if you don't have a history, you are still going to give a differential diagnosis that this could be a drug eruption, arthropod bite, or a prodromal phase of bullous pemphigoid, and then they can easily differentiate between the three, because arthropod bite is going to be usually a single lesion, a drug eruption is going to be a rash, and the BP has some sort of, it's usually an older patient, 70 years, 80 years old, with a vesicular bullous disorder. Case number 10. So again, starting from the top, it looks pretty normal epidermis, but what do we see in the dermis? There's a lot of, what are these cell types here? What is this cell here? Neutrophils. There's a lot of neutrophils. So whenever you see neutrophils, the first thing to ask yourself is, do I see any vasculitis? So whenever you see neutrophils in the dermis, go down to the vessels and do I see any vasculitis? So is there any vasculitis here? And what is the definition for vasculitis? I think we talked about it one more time prior also. So what are the features that you want to see to call anything vasculitis in dermatopathology? Is the presence of this fibrinoid changes around the vessel wall. So you see all this fibrin like material deposition in the vessel wall. That fibrinoid degeneration of the vessel wall along with some neutrophils in the vessel wall is what is needed to call it vasculitis actually. So what we have here is this fibrinoid degeneration of the vessel wall. So if you see that with neutrophils, and then if you go low, you're going to see all this neutrophilic debris. So this is all, these blue dots that you see is the neutrophils nuclei that have broken up. So it's like leukocytoclasia of the, leukocytoclasia means breaking down of the leukocyte. So that is leukocytoclastic, and we already called this, what did we call this feature? Fibrinoid degeneration. So it is vasculitis. So it is a leukocytoclastic vasculitis. But very important to see the fibrinoid degeneration of the vessel wall actually. So what is your diagnosis here? Leukocytoclastic vasculitis. You don't have to go into the etiology because there are 1,000 things that can cause leukocytoclastic vasculitis. So all you need to say in the report is the features are consistent with leukocytoclastic vasculitis, and the differential diagnosis is usually nothing looks like leukocytoclastic vasculitis actually. Case 11. So characteristically, what do we see? There is a lot of spaces in the papillary dermis. So that is dermal edema. And then what do you see in the dermis? Inflammation. And what is the kind of inflammation here? What are these cells here? Neutrophils actually. So there's a ton of neutrophils. So like I said, when you see neutrophils, you have to go down and look for vasculitis actually. So look at the vessels here and compare it to the one that, so this is the vessel wall here. Do we see any vasculitis? No, there is no fibrinoid degeneration or anything. So there is no vasculitis. So it is a neutrophilic dermatosis with papillary dermal edema. So what is your main diagnosis to think of? So whenever you see a neutrophilic dermatosis, your main diagnosis is going to be Sweet's syndrome. Another slide that is going to be on your board exam that can easily be on it because the diagnosis is easy to make. A dense neutrophilic infiltrate in the dermis with no vasculitis and very characteristic the papillary edema that you saw on the top. So when you go back to the slide, so you see this papillary dermal edema and then the dense neutrophilic infiltrate that you see, and usually no vasculitis, and then you can make the diagnosis of Sweet's syndrome. Papillary dermal edema, no vasculitis. Main differential diagnosis to think of is pyoderma gangrenosum. In pyoderma gangrenosum, the main feature that you're going to see, again you're going to see a lot of neutrophils. It is a neutrophilic dermatosis, but the main feature that you're going to see is this undermining ulcer. So you're going to see the epidermis that is partially necrotic and forming almost like an undermining ulcer. So this ulcer is like the epidermis is necrotic and sloughed up, and like the neutrophils are just undermining the ulcer. It's known as an undermining ulcer. So undermining ulcer and the presence of a dense neutrophilic dermatosis will help you make the diagnosis of pyoderma gangrenosum. Again, but clinico-pathological correlation is very important. If you're thinking of this, you have to pick up the phone and talk to your clinician that are you thinking of pyoderma gangrenosum. Case 12. So what do we see here? A lot of inflammation in the dermis, and whenever if we talk of inflammation, we have to go high power and see what is the cell type actually. So what is the cell type here? Plasma cells. So the plasma cells are having a big party here. You can see they're all plasma cells actually. So it's a big plasma cell party. So whenever you see a big plasma cell party, what is your main diagnosis actually? You always have to think, what is the one thing that you always have to think of when you see plasma cells? Is syphilis actually. So you always think of syphilis actually. So you're going to do the spirochete stain, and the spirochete stain is then going to show you the long spiral bacilli, and that is the treponema organisms actually. So this is a case of secondary syphilis actually. So in secondary syphilis, you might see a lot of reaction patterns. You might see some psoriasis from hyperplasia, you might see spongiosis, but the main feature that makes you think of syphilis is the presence of plasma cells in the dermis actually. But so this is important for the board exam. For the board exam, you will have the plasma cells to make the diagnosis. But in real life practice, you have to remember there are around 10 to 25% of cases that might not show any plasma cells. So it doesn't mean that 100% of cases of syphilis are going to show you plasma cells actually. But for the board exam, there are going to be plasma cells to make the diagnosis. So that is the treponemal stain. Diagnosis is syphilis. So usually you see a mixture of reaction patterns. So you may see spongiosis, psoriasiform, lichenoid, perivascular inflammation, but the presence of plasma cells should tell you that most likely this is syphilis and I need to do the spirochete stain, or ask the clinician to do serology. So ask the clinician to do an RPR test, and many times that is an easy way to make the diagnosis, because the RPR is going to be positive, and then the clinician has a diagnosis that my patient has syphilis. Main differential diagnosis to think of is Lyme disease actually. So whenever, again, clinico-pathological correlation is very important. The patient has gone out into the forest, had a tick bite, and then developed the rash, and you're going to see superficial and deep perivascular inflammation with some plasma cells. So you have to think of Lyme disease. Case number 13. So now look at this biopsy actually. When you look at this biopsy, it should tip you off that this is some very classic condition. So what is the shape here actually? Very, very straight actually. Normally whenever you see a skin biopsy, how the bottom will always shrink actually. So you're going to see the biopsy that goes from here, and then normally all biopsies are like this actually. But this one doesn't shrink. What do you see here? It is almost like a straight line. So it is almost like a rectangular biopsy actually. Otherwise, if you look at the other biopsies, let's go back to another one. See this, normally it will always shrink at the base actually. So it's not a rectangular shaped biopsy, but when you look at this condition, they always form this rectangle, very straight rectangle. So whenever you see this, what is the condition that you should think of actually? Some sclerotic condition. What is causing the skin not to shrink is because the dermis is very sclerotic actually, because it's very hard dermis so scleroderma or morphia actually. So why is this happening? Because the dermis is very sclerotic and it does not allow the skin to shrink actually. So you see this rectangular biopsy. So what are the other features of morphia or scleroderma? Is very sclerotic dermis, rectangular biopsy. Usually you see most of the adnexa are gone actually, so you don't see a lot of hair follicles and other adnexa. And then you see the eccrine glands, and normally if you look at another, when we look at another skin, we look at, normally we always see some fat around the eccrine glands. So in this condition you lose all the fat around the eccrine glands. So there is loss of perieccrine fat, loss of adnexa, very sclerotic dermis, and rectangular biopsy. So that then you know that your diagnosis is going to be either scleroderma if it is a more generalized condition, and if it is a localized condition, it is called morphia. So diagnosis is morphia. So like very sclerotic dermis, and then loss of the perieccrine fat, very characteristic features actually. Morphia. So rectangular punch biopsy, no adnexa and loss of periadnexal fat. One differential diagnosis that might come on the board exam is nephrogenic systemic fibrosis. So it almost looks like morphia. So again you have the rectangular biopsy, but what should tip you off that this is nephrogenic systemic fibrosis is the presence of these increased fibroblast actually. So if you go high power, you're going to see increased fibroblastic reaction within the morphia-like reaction pattern, and that should tip you off that this might be nephrogenic systemic fibrosis. Another thing that the board exam might ask you is what is the stain for these fibroblasts. So they're going to stain positively with CD34 and procollagen 1 just for the board exam, and then you can control alt and delete from your brain actually. But for the for the board exam, remember CD34 and procollagen 1. Case number 14. So what do we see here? What is this here? It's a palisade of inflammatory cells. And what is the what are the inflammatory cells? Some are giant cells, some are histiocytes, and some are lymphocytes. So if you see giant cells, histiocytes, what is it? It is called a granuloma actually. So this is a palisaded granuloma. So when you see a palisaded granuloma, what is your main thing to think of? Very classic. This is palisaded granuloma, and within the granuloma you see that the collagen bundles are partially necrotic. They are not completely necrotic but partially necrotic. So that is known as necrobiosis of the collagen. So necrobiosis of collagen surrounded by a palisade of granulomas, and if you do a mucin stain, you are going to see increased mucin within the palisade. So what is your diagnosis? Necrobiosis, that is one of the differential diagnoses for a necrobiotic granuloma is NLD actually. But in this one, why is it NLD? This is granuloma annulare. So another very common condition that you're going to see when you're in practice. We'll come to NLD also, but this is when you see this palisaded granulomas around necrobiotic collagen with increased. So this is another palisade here. This is one palisade here. This is another palisade here. So this is a very classic feature for granuloma annulare actually. And if I do a mucin stain, I'm going to see increased mucin in the granuloma. But like you said, the main differential diagnosis that you have to think of is NLD and rheumatoid nodule actually. So these are also, both of them are going to present with the palisaded granulomas that you saw in granuloma annulare. How is it different from granuloma annulare? So this is an example of rheumatoid nodule. So one, where is the granuloma? It's mostly in the deep part of the dermis. So they are in rheumatoid nodule, the granulomas are usually in the deeper part of the dermis or in the subcutis. And what is, like, let's go to the granuloma. So here's the granuloma, nice one here. So you can see the palisade of granuloma. But do we see necrobiotic collagen here, or what do we see here actually within the granuloma? It's more fibrinoid degeneration. It is not that collagen bundle that is partially necrotic actually. So this is more like a fibrinoid degeneration surrounded by this palisade of granulomas. And if you see that, then you think if the granuloma is located in the deeper part of the reticular dermis, you have to think of rheumatoid nodule. In NLD, very classic, what are you going to see? Think of a cake basically. So you're going to see the layered pattern actually. So layered pattern means sclerosis, inflammation, sclerosis, inflammation, sclerosis, inflammation, sclerosis. So it's like a layer of inflammation and sclerosis. So this is known as a layered pattern or the cake pattern, and very classically seen in necrobiosis lipoidica. So, and when you go high power, what is the inflammation composed of? Again the same, lymphocytes, giant cells and histiocytes actually. You can see a lot of giant cells. And then if I go and look for plasma cells, I'm also going to see some plasma cells in NLD. But very classically, how you can make the diagnosis is when you see this layered pattern of inflammation and sclerosis, then you think of NLD. And the last case, so now if you start looking at the biopsy, the main action is in the, so if your epidermis is normal, dermis looks pretty normal, but then in the subcutis you see some inflammation. So when you see inflammation in the subcutis, where is the inflammation? Is it in the lobules or is it in the septa? It's mostly in the septa. So what is the kind of inflammation that you see here? Is again a little granulomatous. You see all these giant cells, lymphocytes, and then the septa are also thickened. So you see thickened septa with inflammation mostly limited to the septa, some lace-like pattern of infiltration into the lobules, but mostly limited to the septa, and some giant cells. So what is your diagnosis? Pardon? It is a panniculitis, but a form of septal panniculitis. So which is the classic prototypical lesion that you have to know for septal panniculitis? Is erythema nodosum actually. So this is very classic erythema nodosum. So erythema nodosum you're going to see is the thickened septa and the granulomatous inflammation within the septa actually. And the only differential diagnosis that you need to know for erythema nodosum is erythema induratum actually. So erythema induratum, now the inflammation is mostly where? Now it's going into mostly into the lobule. So this is a pattern of lobular panniculitis. So there is inflammation in the septa, but also now in the lobules. And very classically in erythema induratum, you want to see the lobular panniculitis and the presence of vasculitis. So you want to see vasculitis with lobular panniculitis to make the diagnosis of erythema induratum. Previously, the most common cause was for erythema induratum was tuberculosis. So people used to do the AFB stain. Nowadays, many people still do the PCR because the AFB doesn't give a high yield. So the PCR for TB is done, but most of the times it is negative. But that was the most common cause for erythema induratum. So those are the 15 diagnoses that you should know, especially for your board exam actually. Thank you for your time. And if you want to see these slides again on your own computer, and if you want to see the entire presentation with the slides, what you can do is just send me an email to skinpathology@gmail.com and I'll share the presentation with you. So then you can just log into Path Presenter and actually see the whole presentation with the digital slides on your own computer actually. And all the slides have been annotated, so you can actually look at the annotations and see where are the findings actually. So if you send me an email to skinpathology@gmail.com, I will share the presentation with you, so you can even see the digital slides along with the presentation. Thank you.